Well, good afternoon, everyone. This is Larry Boris, the National Association of Worksite Health Center. I'm pleased to have you for our next session on auditing for clinical quality assurance. We're pleased to have this session Dr. David Cloud, formerly Chief Medical Officer at Activate Health. David has spent over 30 years studying and leading health improvement initiatives for their organizations as a National Medical Director at Optum. He helped in creating their organization and their patients' right to care and see the right kind of providers. And at Activate, he had created and implemented numerous mechanisms to facilitate active clinical involvement. Currently, he's with Benefit Docs, and I'll turn it over to him. David, all yours.
Well, thank you very much, Larry. So good afternoon, and I want to make this presentation as interactive as possible for you. And so if you're able to click your screen so that you can see me, that would be great. And also I've worked very hard to try to limit this to 25 minutes, and so that there will be opportunity for questions. So I don't know if you see, there's a button for you to type in questions, and I'd love it if you'd ask questions. I hope this provokes some questions. If you can see me, you will see that I'm wearing a mask just out of an abundance of caution in light of some of the COVID talks we had. And the mask has a Chicago flag on that. I'm wearing a Chicago flag mask because I am Chicago. So now that I've said that, I'm going to take it off just so now the joke is over so you can hear me better and I don't have to deal with that. As Larry said, my name is David Claude. For the last decade, I've been working full-time to try to improve healthcare provided to specific employee populations, including 4 years that I spent as National Medical Director at Optum, and then 6 years as Chief Medical Officer at Activate Healthcare. And I will say, in light of the recent presentations that we had about advanced primary care or advanced practice care, which I thought were excellent, another way that we could entitle this talk is, getting to that advanced practice care in a more expeditious fashion, or harnessing the market forces to get to that advanced practice care level. I want to make 3 assertions today. The first one is that there is a significant quality problem in healthcare. The second is that the quantitative measures that are often relied upon by on-site clinic sponsors or on-site clinic customers to assess quality give an incomplete understanding of the quality of care that's being provided in the clinic. And then the third assertion is that worksite healthcare sponsors or on-site clinic sponsors or customers are well positioned as a customer to more fully assess the quality of care provided in their clinics. And by doing so, they will be able to positively influence the quality of care that their employees receive in their clinics. So Mark, if you can go ahead and go to the next slide. So as I mentioned, my first assertion was that there's a significant quality problem in healthcare. And while I don't have time to fully vet this out, I thought one way to do this would be to share with you what some healthcare insiders say about the state of healthcare. First comment here is by Dr. Toby Cosgrove and also Dr. Thomas Lee. And this was stated in 2014, and I want to read this comment. Quote, "Despite wondrous advances in medicine and technology, healthcare regularly fails at the fundamental job of any business to reliably deliver what its customers need." Dr. Cosgrove, at the time when he said this, was CEO of Cleveland Clinic. He's a cardiovascular surgeon and was the CEO of Cleveland Clinic when he said this. And Dr. Lee is the Chief Medical Officer for Press Ganey. And this was in Harvard Business Review. Mark, if you can go ahead and go on to the next slide. So in 2020, just recently, in the July 2020 issue of the oncology portion of JAMA, Peter Pronovost and Dr. Dietz said the following: "Despite dramatic advances in medicine, healthcare still causes harm too often, costs too much, and improves too slowly. How is it that we are, quote, failing patients, unquote, when we are passing our accreditations and following available guidelines. And so Dr. Pronovost, as I said, I wanted to let you know what Healthcare Insiders were saying. Dr. Pronovost was the Senior Vice President for Patient Safety and Quality for 9 years at Johns Hopkins. He's an intensivist. He's currently at University Hospitals in Cleveland, the Chief Clinical Transformation Officer. And then Dr. Dietz is also there, an oncologist there. And I just want to say this one more time, because I think these statements need to be heeded. Despite dramatic advances in medicine, healthcare still causes harm too often, costs too much, and improves care too slowly. How is it that we are failing patients when we are passing our accreditations and following available guidelines? Mark, if you can go ahead and go to the next slide. This is a quote that some guy in Chicago said. I saw him on the street and happened to write it down. Despite their wondrous advances, RFPs, HEDIS measures, and performance guarantees alone will not drive the quality improvement needed in healthcare. Qualitative assessment of healthcare quality by purchasers is needed to effectuate change at the pace we need. So I want to go ahead and go to the next slide, Mark. We have a poll question. As I said, I wanted to see if we could make this interactive. So we'll see, how this works here. So the first question is, and I would just love it if you could just vote. I can't promise you this, but hopefully that might influence your ability to get a prize. I'm just hoping that's the case. What percentage of healthcare spending is spent on waste? If you could go ahead and enter in what you think the answer is. And then Larry or Mark, will you share with us kind of what the results are after about 10 or 20 seconds?
Yeah, we'll give them about 15 seconds. Again, many of the people may not have access to the poll,
okay,
so it's not going to be great. We only have one responding here. So why don't you just go ahead, David?
Okay, so let's see. I'm seeing some answers. Yes, it was spotty. But I think the best answer, I would suggest 25% is the best answer. Now, there have been numerous studies that have been published that provide evidence that there's significant waste in healthcare. And numerous studies, I would say, at least over the last decade. And actually studies show that private employer-sponsored care, patients that are getting their care through private insurance, there's significant waste. There was a recent article in JAMA published in October 2019 in an article entitled "Wasteful Healthcare Spending in the United States," and they came up with 25% was their estimate. Now, they looked at 6 categories of waste, and I will say, I do suspect that a well-managed on-site health clinic has already likely minimized some waste from 3 categories of waste, and that's administrative complexity, fraud and abuse, and pricing failure. I think the on-site clinics provide a great opportunity to address those things. But there are 3 categories of waste that are still significant contributors to waste, and I suspect that these categories are not being assessed and addressed by the on-site clinic customers to the extent that they could be. And these categories are failure of care delivery, failure of care coordination, and over-treatment of low-value care. So just to reiterate, 25% of healthcare spending is estimated to be spent on waste. And the waste categories include failure of care delivery, failure of care coordination, over-treatment of low-value care. We have a tremendous problem in healthcare, and when you think about it, a quarter of the spending is thought to be waste, and you're talking about a quarter of a very, very, very large spend. Mark, if you can go ahead and go to the next slide. So yesterday, a speaker referenced the National Association for Worksite Health Centers or Worksite Health Centers guidebook for measuring performance of worksite health centers and wellness centers. And I just wanted to reiterate this and remind you of this excellent resource so that you can avail yourself of this when you're going about selecting or evaluating a worksite health center. Mark, if you can go ahead and go to the next slide. And I will say some of what I'm going to be talking about is covered in that book, and others are different. Okay, so I always like to kind of get to brass tacks, honestly. So to illustrate what I'm talking about, quality problems, let's look at this real life example of care that was provided. So, and this is a real case that happened. So the nurse says, "Jill, I see you're taking birth control pills. Tell me how you're taking them." And Jill says, "Well, some days I take 3, some days I don't take any. On weekends, I usually take more." And the nurse says, "Well, how did your doctor tell you to take them?" And Jill said, he said these pills were to keep me from getting pregnant when I have sex. So I take them anytime I have sex. So I think that intuitively you can sense that this patient, there's a decent chance this patient did not receive high quality care from the doctor. But just to understand quality more, I think it's helpful to just dissect this a little bit more and be able to explain, well, why was this that the patient didn't get high quality? Mark, if you can go ahead and go to the next slide. So I think in order to dissect, why we would say this patient didn't get good quality healthcare, at least as it relates to primary care, I would encourage you to use this working definition for defining quality healthcare. And the working definition that I think is useful is that quality healthcare is care that produces care recommendations that are needed, and that means based on an accurate diagnosis, supported by evidence. That means the care recommendations there's evidence that they work. And then but even, and maybe most importantly, that these care recommendations are delivered in a way that gives the patients the knowledge, the skills, and the confidence that they need to pursue these recommendations. So if you think about, that last patient example in terms of whether the care was needed or supported by evidence or delivered in a way that increased the patient's knowledge, skills, and confidence, the care very likely was needed. It was based on an accurate diagnosis. The Jill very likely, was a woman that was of reproductive age and wasn't desiring contraception. It very likely was supported by evidence. There's good evidence that suggests that oral contraceptives are effective, but where the care was likely lacking and given in a poor quality way was it was not delivered in a way that she left with the knowledge and the skills and the confidence that she could follow the recommendations or to take the birth control pills or the oral contraceptives in a way that they needed to be taken. And so this is unfortunately, this type of care and this level of care that's illustrated in this example actually happens not infrequently in our country and leads to some of the waste that we've been talking about. All right, Mark, if you can go to the next slide. So I would like to talk about another patient example in a second. But prior to that, I want to go over another issue that's related to this and explains why understanding and assessing quality care is so important. So there's an idea of informational imbalance, or a concept of informational imbalance. Sometimes it's referred to as informational asymmetry, that can exist between a buyer and a seller in a market. So as it relates to what we're talking about, there can be an informational asymmetry or imbalance that exists between healthcare purchasers and provider organizations, or healthcare purchasers and on-site clinics. And so actually I would say, and I want to look at the informational asymmetry that exists for three factors. So one of healthcare, one is, or attributes of healthcare. One is quality, one is service, and one is cost. The reason why I'm emphasizing the informational asymmetry for quality, service, and cost is that value has traditionally been defined as quality plus service divided by cost. That's how economist Michael Porter defined it. And so if you have somebody that's purchasing healthcare, or a group that's purchasing healthcare, and you don't have a worksite clinic, just because of if you're not a healthcare organization yourself, you're purchasing healthcare, your core competency is not healthcare. And so just because of that, and because of the complexity of healthcare, the provider organizations are always going to know a lot more about quality, service, and cost. Now, if you go to the next slide, Mark, one thing that I think is so exciting about a worksite clinic is, in my experience, when you had a worksite clinic, that helped the healthcare purchasers become much more knowledgeable about two of these components, and reduce the information imbalance between the buyer and the seller. And that is, they quickly become much more knowledgeable and astute about service and costs. So just to flesh this out, let's look at medications and labs. If you have an on-site clinic, an astute client is quickly going to become very much aware and more aware about the cost of medications that they're paying for, and also the labs. And not only that, they'll know about the service that their employees are getting. They'll know if the person that draws the blood can do it without inflicting too much pain. They'll know if the clinic staff wears their mask correctly in the time of COVID. They'll know if it's easy to get into the clinic to get medications. But what I would assert is that at present, healthcare purchasers often don't know too much about the quality. So if you think about the medications and labs, what the purchasers will not know is whether these labs and these medications that they're buying were needed. And actually, conversely, they will not know if there's medications and labs that were needed but weren't ordered. So, and when you have an on-site healthcare clinic in the US where 25% of healthcare spending is thought to be waste, lack of knowledge about the quality related to medications and labs may result in you getting a good price, and I put that in quotes, a good price for labs and medications that are not needed. The reason why I put that in quote is, of course, it's better to pay less than more for labs that are not needed, but really the best is not to pay for them at all. So let's go ahead and go to the next slide, Mark. Thank you very much. Okay, so where the good news is that I would suggest it's possible for buyers in healthcare, especially when you have a worksite health clinic, to know just as much about or to reduce this information asymmetry that exists between quality, service, and cost, so including quality. Now, why have I kind of taken this digression? Why am I talking about this in the first place? Mark, if you can go ahead and go to the next slide. Let's see. Mark, are you there? Sorry, Mark. Oops.
Sorry, David, it took a little while for the pictures to load.
Okay, oh, that's fine. Okay, so let's see, hold on. Okay, so why am I talking about this? Why am I digressing here, and talking about this informational imbalance or informational asymmetry between buyers and sellers in healthcare? Well, the first reason why I'm talking about is just simply based on my observations over a decade of working with self-insured employers whose core competency is not healthcare, and I've seen firsthand this information asymmetry and seen its effects. But in addition to that, I will tell you, because of what I witnessed and because of some of the hypotheses I had developed myself, I was very reassured and when I learned that there was a Nobel Prize that was awarded to an economist for this exact idea. And so basically in 1970, an economist, George Akerlof, published a paper, and it was entitled "The Market for Lemons, Quality, Uncertainty, and Market Mechanisms." And in a nutshell, and he ended up getting the Nobel Prize for this in about 1990, but in a nutshell, what he said was, when purchasers can't differentiate between poor quality, i.e. lemons, and high quality peaches, then what happens is that the market responds by producing a lot of lemons. And that's actually, and obviously not good for the market. So the idea is that being able to differentiate between low and high quality is very important for the market to work well. When we go to the next slide. So I just would ask you this, we don't have to do the mechanism because I think we're starting to run a little low on time, and I want to make sure that we have time for questions. So I would ask, this is a question geared towards people that are on the healthcare purchaser side and that either have a clinic right now or would be considering one. I would just ask you, if you're meeting with the clinic provider team, again, when you're the customer, would you know what questions to ask to assess quality, and would you also know how to interpret the answers that were given to you? I don't know. I don't know how people would respond, but I think it would be, somewhat challenging if your core competency is not quality, if your competency is not clinical medicine. Mark, can you go ahead and go to the next slide? Okay, so I want to go over another patient example, and I want to, because I think this example kind of illustrates this concept of what is picked up by quantitative measures and what's not. And so just forget looking at the slide for a second and hear me out. Just think about an employee that presents to your clinic. They haven't seen a doctor in 10 years. They're diagnosed with hypertension, and they're told to change their diet and exercise more and come back to the clinic in 4 weeks. Those are the care recommendations. And then the patient doesn't schedule the follow-up appointment, and consequently, there's no follow-up in 4 weeks. So my first question would be, well, what would the quantitative measures assess about the quality of care for this situation? And the first thing is, I would say he might fall into a HEDIS measure for blood pressure or a performance guarantee. And the reason why I say he might is because sometimes the HEDIS measures that assess quality for blood pressure or the performance guarantees are limited to patients where on the EMR it's marked that the clinician is the patient's PCP, and if that's not even marked, that doesn't even roll up into the performance guarantee or HEDIS measure. But regardless of that, think about what will not be assessed by a HEDIS measure, or even a performance guarantee for hypertension. Number one, is the care needed? So was the diagnosis of hypertension correct in the first place? The literature suggests many people are not correctly diagnosed for hypertension, much less many other things. Number two, is the care supported by evidence? Was it appropriate to start with lifestyle changes? Or should medications have been started? That won't be picked up. And then again, most importantly, was the care delivered in a way, kind of going back to what Dr. Kennard said earlier, did the doctor just tell the patient what to do, or did the doctor effectively give the patient some tools, and in so doing, increase the patient's knowledge, skills, and confidence about how to pursue these lifestyle changes? Then, and when the patient didn't show up in 4 weeks, what happened? How did the clinic staff know this? How did they respond? Did they follow up with the? Did they reach out effectively to the patient and find out how they could help? So just now, looking at these slides, these are examples of what I'm talking about the need to go beyond quantitative measures to assess the quality of the care that's going on in your clinic. And so some of these items we just discussed in this example. Other things that I think would be helpful to know, beyond like what might come out in looking at an actual chart, would include just questions and assessing the oversight by the medical director and supervising physician of a care provided by a nurse practitioner, for example, or oversight of a care provided by a physician, by the medical director. Reports used to identify potential low-value practice patterns. Reports used to identify people that are falling through the crack and need some outreach, and then also incident reporting. Larry, if you go to Mark, if you go to the next slide, I think we're almost out of time. So I'm going to really hurry here so we can hopefully have some time to review some questions. In conclusion, so first of all, I want to thank you for coming on this last day of the conference and persevering to the end of this. Number two, I appreciate if you would consider the following assertions that I made. Number one, quality is a significant and costly problem in healthcare. And then number two, as a customer, better understanding and assessing the quality will have a beneficial impact on the care that's provided in your clinic. And then from a recommended next steps, if you are a customer, what would I recommend? How do you go about assessing quality beyond the quantitative measures to reduce this informational asymmetry? What I would suggest is as follows. So number one, have your clinic vendor randomly pull some charts and ask them, I just want to say, without the clinical background, it's going to be hard for you to assess whether the care is needed based on an accurate diagnosis or supported by evidence. But what you can look at is the patient plan, the written patient plan that's supposed to help give the patient's knowledge, skills, and confidence to pursue the next steps. And you can just look at the patient plan and answer, put yourself in the shoes of the patient and just say, if you had left, or if you had gone to the clinic, forgot what was said, and now had to rely on this patient plan, would the patient plan, was it written in patient-friendly language? Would it help you know what was wrong, what the next steps were that I needed to do, why it was important? By the way, I know I'm sure there's probably objections about HIPAA, and I just want to assure you that the Department of HHS has provided guidance about de-identification of protected health information in accordance with HIPAA privacy rule. So this is something that can be done, and this gives you a way to start assessing the quality in a qualitative way. The other things I would suggest is just simply to be asking if you're a customer, ask your clinic team in a very Missouri-like way, I would say, meaning Missouri is the show me state. Have the clinic show you, how do they handle incident reports? How do they learn from incidents? How do they show you, how do they handle referrals? If they say they're going to refer to a high quality, low cost referral, and make sure that our specialist, and make sure the specialist has what they need. How do they do that? I would really encourage you ask for demonstration of this. And then also, if they're going to identify patients in need of outreach, how do they do it? Have them show you. So I want to thank you again. I hope we have a minute or two left for questions. Larry, if there's no questions, maybe you could pretend and make up one.
Well, thank you very much, David. That was great information. And, quality is something that employers expect from their providers and their health clinic vendors, but they often don't know what to ask for. It's like years ago when I was working with an employer about their pharmacy performance measures for their PBM. And initially said, well, I just want to find out what % of drugs are generics versus brands, and what % of my people are on that. And I said, well, if you really want to define what's going on, why don't you ask how many of my people who are statins are adherent? Because it gives you a lot more information than an overall. And so drilling down and knowing the questions to ask is really important. So this has just been great. Thank you very much for your time. And thank everyone for participating in this program. It has been recorded and will be available to you after the session.